Welcome, dear viewers, to another enlightening episode on our channel. Before we dive in, don't forget to hit that subscribe button and the notification bell to stay updated on all things health-related. Today, we dive into the intricate world of Kawasaki disease. Kawasaki disease, KD, often referred to as mucocutaneous lymph node syndrome or Kawasaki syndrome, is an acute febrile sickness that mostly affects the medium-sized arteries in children. In high-income countries, the most common cause of acquired heart disease in children. Next to Hainok-Shunline purpura, Kawasaki disease is the second most prevalent childhood vasculitis. Unsuitable care can result in coronary artery aneurysms. While Kawasaki disease has been documented in children of different backgrounds, Asian children, especially those of Japanese ancestry, are the most frequently affected. Additionally, males are somewhat more likely than females to have Kawasaki disease, but it seems that females are more likely than boys to suffer from arthritis. Boys experience mortality and major problems at a higher rate than females. Typical among kids from 6 months to 5 years. Beyond this, they are more likely to have an incomplete presentation and are also more likely to have a suboptimal outcome. Now exploring the etiologies of Kawasaki disease. The exact cause of Kawasaki disease remains unknown. One prevailing hypothesis suggests an infectious origin, but intriguingly, no single infectious agent has been definitively identified. Also, a combination of factors including autoimmune reactions and genetic predisposition have been proposed as potential contributors to the development of KD. Infections suspected of having a connection with KD. These include parvovirus B19, Neisseria meningitidis, bacterial toxin-mediated superantigens, Mycoplasma pneumoniae, Klebsiella pneumoniae, adenovirus, cytomegalovirus, rotavirus, measles, Epstein-Barr virus, tick-borne diseases, rickettsia, and Propionibacterium acnes. Moreover, genetic predisposition appears to play a significant role in Kawasaki disease. Studies have shown that siblings of affected children have a substantially higher probability of developing KD, approximately 10 to 20 times higher than the general population. Phases of Kawasaki disease. Divided into 3 stages: acute, subacute, and convalescent. Some authors add a fourth, chronic phase. The acute stage begins with an abrupt onset of fever and lasts approximately 7 to 14 days. The fever is typically high-spiking and remittent, with peak temperatures ranging from 102 to 104 degrees Fahrenheit or higher. This fever is not responsive to antibiotics and can persist for up to 3 to 4 weeks if untreated. With appropriate therapy with IVIG, the fever typically remits within 36 hours. In addition to fever and the diagnostic criteria mentioned later, signs and symptoms of this phase may include the following. Irritability, often out of proportion to the degree of fever and other symptoms. Aseptic meningitis. Anterior-uveitis. Otitis media. Myocarditis and pericarditis. Pneumonitis. Hepatic, renal, and GI dysfunction. Orchitis. Myotitis, vulvitis, urethritis. Perianal erythema and/or desquamation. The subacute stage starts after the fevers have subsided and lasts until weeks 4 to 6. Hallmarks of this stage are desquamation of the digits, thrombocytosis, and the development of coronary artery aneurysms. At this point, there is the greatest chance of abrupt death. During this time, some people develop arthritis or arthralgia, which both tend to favor the major weight-bearing joints. Anorexia, conjunctival injection, and chronic irritation are other features of the subacute stage. The prognosis is less favorable if the fever lasts longer since there is a higher chance of heart problems. In the convalescent phase, complete resolution of signs, usually within 3 months of presentation. The acute phase reactants and lab values return to baseline at the start of this phase. Cardiac abnormalities may still be apparent. Larger aneurysms may expand, and MI may occur. The chronic phase is for patients who have developed cardiac complications. There are 2 forms of KD, complete and incomplete. Let us look at the complete form first. Diagnosis of complete KD requires a fever of at least 5 days duration along with 4 or 5 of the principal clinical features. Recent version of the AHA guidelines suggests that if a patient presents with 4 or more of the principal criteria, KD can be diagnosed on day 4 of fever. Patients who present with coronary artery disease can be diagnosed if they have at least 3 of the 5 major diagnostic criteria. The criteria include extremity changes. Erythema of the palms and soles, sometimes accompanied by firm and painful induration of the hands or feet that can impede ambulation. Desquamation of the fingers and toes which begins in the periungual region. Within 2 to 3 weeks after the onset of fever. 3, Bowes lines, deep transverse grooves across the nails, may be present 1 to 2 months after fever onset. Rash, typically diffuse and maculopapular, but can take on a variety of forms. Bullous, vesicular, and petechial rashes are not consistent with Kawasaki disease. Oropharyngeal changes. Erythema, fissuring, bleeding, and or crusting of the lips. Strawberry tongue with prominent fungiform papillae. Diffuse erythema of the oropharyngeal mucosa. Bilateral, non-exudative, limbic sparing, painless bulbar conjunctival injection, greater than 90% of patients. Acute unilateral non-purulent cervical lymphadenopathy with lymph node diameter of at least 1.5 cm, least common criteria present. Kawasaki disease is a medium vessel vasculopathy, any organ system can be affected. Other common findings in addition to the diagnostic criteria include neurological, irritability, aseptic meningitis. GIT symptoms, abdominal pain, vomiting, diarrhea, gallbladder hydrops. Arthralgia/arthritis. Dysuria. Inflammation at a recent, within 6 months, BCG vaccination site. Consider incomplete KD in. A child with fever for at least 5 days combined with 2 or 3 of the principal clinical features or an infant with 1 or more of the following features. Fever greater than or equal to 7 days. Prolonged fever and unexplained aseptic meningitis. A child or infant with prolonged fever and shock. Cervical adenitis not responsive to oral antibiotics. The treatment for KD and incomplete KD is identical. The AHA recommends that when fever for 5 days or longer plus 2 or 3 of the principal clinical features are present without an alternative explanation, a C-reactive protein, CRP, level and erythrocyte sedimentation rate, ESR, should be obtained. If the CRP level is less than 30 and the ESR is less than 40, the child is monitored clinically. Re-evaluation of these laboratory markers takes place if fevers persist, and an echocardiogram is performed if skin peeling develops. If the CRP is 30 or higher or the ESR is 40 or more, the next step is to obtain supplemental laboratory studies. Abnormal limits include the following. Albumin 3 or less. Anemia for age. Elevated ALT level. Platelets greater than 450,000, after 7 days of fever. WBC count 15,000 or greater. Urine WBC 10 or greater. If 3 or more supplemental laboratory criteria are positive, a diagnosis of incomplete KD is made. The child should have an echocardiogram and be treated. If a patient has a positive echocardiogram with or without positive supplemental laboratory criteria, the patient should be treated. If fewer than 3 supplemental laboratory criteria are positive, the child is monitored clinically. Re-evaluation of these laboratory studies takes place if fevers persist, and an echocardiogram is performed if skin peeling develops. Complete Kawasaki disease is a clinical diagnosis. Laboratory tests and imaging provide support for diagnosis, assessment of severity, and monitoring of disease, treatment and when assessing incomplete KD. A typical initial laboratory evaluation may include a complete blood count, CBC, electrolyte panel, renal function testing, liver enzymes, albumin, erythrocyte sedimentation rate, ESR, C-reactive protein, CRP, and urinalysis. The abnormal laboratory values may require 6 to 8 weeks to normalize. Research has shown 2 urine proteins that have been identified as potential biomarkers of KD, meprin A and filamin C. For cardiac complications and routinely, an ECG is done. Shows tachycardia, prolonged PR interval, STT wave changes, and decreased voltage of our waves may indicate myocarditis. Q waves or STT wave changes may indicate MI. Echocardiography is the study of choice to evaluate for coronary artery aneurysms. Serial echocardiograms should be obtained, preferably at the time of KD diagnosis, at 1 to 2 weeks, and at 5 to 6 weeks after the onset of the illness. These may need to be performed more frequently in high-risk patients. In addition to evaluating the coronary arteries for dilation and thrombosis, the baseline echocardiogram is also performed to evaluate for other signs of cardiac involvement. This includes aortic root dilation, depressed contractility, ventricular and valvular dysfunction, and pericardial effusion. CTA, MRA, and/or cardiac catheterization are often later utilized in cases of children with significant coronary artery aneurysms. Preventing coronary artery aneurysms and other heart problems is the aim of KD therapy. Aspirin and IVIG are the cornerstones of the KD therapy regimen. It is recommended that all individuals diagnosed with KD be admitted to the hospital to get IVIG, undergo echocardiography, start taking aspirin, and be monitored until fevers have subsided. Intravenous immunoglobulin, IVIG. IVIG relieves acute inflammation. IVIG should be given within the first 10 days of illness but should also be given to children diagnosed after 10 days if there is evidence of ongoing fever and/or inflammation. A second dose should be given to children who do not respond to the first dose, as demonstrated by persistent or recurrent fevers 36 hours after the end of the first IVIG infusion. Hemolytic anemia can occur typically after a week of IVIG infusion, particularly for children receiving multiple doses. Post-IVIG vaccination, live vaccines, e.g. measles and varicella, are contraindicated for 11 months. For IVIG-resistant disease AHA, recommend a second dose of IVIG, methylprednisolone, a longer tapering course of prednisolone or prednisone plus IVIG, or infliximab be considered for patients resistant to IVIG. Aspirin. Daily dose until normal echo on follow-up, minimum 6 weeks. Avoid non-steroid anti-inflammatory medications whilst on aspirin. There is minimal risk of Reye syndrome with low-dose aspirin. If on long-term, low-dose aspirin, better to receive an annual influenza vaccine and be vaccinated against varicella. Corticosteroids. Corticosteroid use in KD should be considered in consultation with specialist advice. Use adjunctive glucocorticoids with IVIG as initial therapy for patients with acute KD who are at high risk for IVIG resistance or the development of coronary artery aneurysms. Consider discharge when afebrile and well at least 36 hours after treatment. Children are on a daily dose of aspirin. A follow-up plan is in place, including a general pediatric review and repeat echocardiograms planned with cardiology. Thank you for joining me today to learn about Kawasaki disease, a condition that primarily affects children. Remember, early recognition and prompt medical attention are crucial for the best outcomes. If you found this video helpful, please give it a thumbs up and share it with others who may benefit from this information. Don't forget to subscribe and click the notification bell to stay updated on our latest content. Thank you for watching, and I'll see you in the next video. Stay informed, stay healthy.